Madam Chairman, Dr. Rajiv Modi, other eminent dignitaries, and friends. I must first congratulate and be thankful to the organizers of this IAMICON 2014, Cardiovascular Pharmaceuticals, for a very noble cause. Secondly, I must confess that I always wanted to meet an individual who, by his very wisdom, saved millions of lives over the years. I must confess that I didn't know that it was Mr. Modi, Rajiv's father, who had negotiated the patent law in such a way that in India the patent applied for the process and not for the drug. By this classical stroke, over the years, I think millions of lives were saved by two things. Number one, access to medication. And second thing, access to affordable medication. Third thing, to continue that good work. Now that Cardiovascular Pharmaceutical has been working so hard in the field of innovation, and we'll hear in other presentations about the innovations achieved by the Cardiovascular Pharmaceuticals in cardiovascular field, in tuberculosis field, in oncology, immunology field as well. Without wasting very much time, I thought that I must share some of my knowledge with you. And to begin with, in London we have a very famous underground railway system, we call it Tube. And I made a very simple observation, that when you go from the Westminster on a Jubilee line underground tube towards east end of London, so traveling from Westminster, each tube stop represents nearly 1 year of life expectancy lost. You know why? Because in the east end of London, the majority of population is South Asian. So we have a dubious distinction of being at a very high risk of premature coronary artery disease. If we look at myocardial infarction and stroke in India, more than 2/3 of myocardial infarctions and CVA cases are younger than 55 years of age. 70% of the cases of MI and CVA, they have diabetes and hypertension together. Heart attack is 6 times more likely in diabetics. And the most common risk factors which could be modifiable in terms of saving lives in patients with MI was diabetes and hypertension. I thought that I must look at it in a comparative way. And we look at the MI and CVA, I wouldn't say only India, but I would say Indian population anywhere in the world. They get an MI at the age of 55 or below. But if you look at the UK, average age is 75. If you look at US, the average age is 65. Recently, the data, which was looked at by the American College of Cardiology in India, through an ongoing study called Clinical Study, they looked at more than 85,000 patients from an outpatient point of view. And they saw that 60,000 of these patients had heart disease. 50% of the heart disease patients had hypertension. So half of them had hypertension, and 25% were diabetic. 32% of diabetic patients had heart disease. 10% had heart failure, and 70% had hypertension. So hypertension, diabetes, and we'll see the cholesterol is causing a problem in these patients prematurely. This is a photomicrograph of a coronary artery in which a lumen has been reduced to only a small slit. And you can see the atheroma with some hemorrhage within it as well. The name of the game for a cardiologist is to keep the lining of this lumen robust and protect the lining from damage. Because if the lining is damaged, the platelets will stick to it, blood will clot in it, leading to myocardial infarction. These are the CT scans you all know of a stroke. This is where I play. I'm an interventional cardiologist, and I see this angiogram on a daily basis with a clot in the coronary artery in the main LAD, which we reopen, stent to restore the blood flow to the myocardium to prevent any damage happening to the left ventricle. I would now like to take you through a journey to have a look at the risk to patients who come to the hospital with MI, and over the next 1 year, and how that risk of death or reinfarction is associated with risk factors. When the patients come to the hospital in UK, every patient is risk scored on the GRACE registry scale. That tells us about risk of immediate death within the hospital, death over the next 3 months, 6 months, and a year. I think this is a very important slide because I think we are so busy in managing patients in the hospital with myocardial infarction. We tend to ignore the very fact that over the year, over the first 1 year after discharge, there is substantial high risk of mortality. If you look at in-hospital mortality is 7.5%, which rises to 14.8% by 1 year. Most worryingly, 50% of these patients die suddenly of VT and VF, 50% within the first 3 months, and 33% within the first 3 weeks of an event. So, the mortality doubles within 1 year of discharge from the hospital. If we look at the impact of risk factors on mortality of these patients, or even at the impact of these risk factors to the mortality of people who have not yet become patients, we immediately see that the patients who come to the hospital with acute ST elevation myocardial infarction, there's a difference in your mortality depending on your diabetes status. You can see that diabetic patients who come to the hospital with ST elevation MI have a risk of dying twice as compared to non-diabetics. And same is true for patients who come to the hospital with non-ST elevation MI. If we look at the risk of an event in a population of patients with a high cholesterol of 6.7, which is on the right side of your screen, with a high LDL of 4.9, the risk is about 4.5% in the community. If we look at individuals whose cholesterol is lower than this, with 5.4 and an LDL of 3.5, the risk is lower. If we go down further in cholesterol, we see that the risk is further low. Now, if you look at the left side of your screen, with lowest risk of event rate, with a low cholesterol of 4.5. If we keep the cholesterol same, which is low at 4.5, but only change an HDL of below 1, 1 is normal. So if your HDL is 4.8 with even a low cholesterol, your event is as high as those individuals with high cholesterol. And that's the story of Indian people. That although their cholesterol is low, I'm talking of in comparison with white people, their event rate is high, 6 times as high as compared to white people. If we make another change to this group of people with low cholesterol and low HDL, if they become diabetic, the risk is extremely high. And these are the Indian individuals with low HDL and diabetics. So what happens to these diabetic people? How do they die? Well, majority of them die of ischemic heart disease. What does that mean? What we normally keep doing is keep addressing their HbA1c to bring it lower and lower and low. We know that bringing the HbA1c lower does not have relatively high impact on mortality. What brings their mortality down is lowering their cholesterol and lowering their blood pressure. So again, the impact of risk factors on mortality. So what is the risk of a type 2 for dying of a mitral infarction? If you look at the blue bar, these are not diabetic individuals, but with the previous history of mitral infarction. They have an incidence risk of 18.8%. But if you look at the green bar, these are diabetics with no previous heart attacks. Their risk is the same as those individuals with previous MI. So this slide tells us that type 2 diabetes is myocardial infarction equivalent. And that's why, at least in UK, we treat all type 2 diabetics without any history of mitral infarction with the same medication as we treat those who have had a previous MI. That means aspirin, statin, ARBs, and all other drugs. If you look at the blood glucose level at the time of admission with mitral infarction in patients who have no previous history of diabetes, we need to realize that higher is their blood sugar level at admission, higher is their mortality. This is a very, very important and common slide which you have all seen in the past. This is a study from Salim Yusuf, which is intra-heart study, and they looked at 9 risk factors. And you may realize that probably abdominal obesity is one risk factor which actually brings all risk factors together. This slide I'm trying to portray that more number of risk factors an individual has, higher is the risk of an event or even mortality from that event. So if you look at no risk factors, if your hazard ratio is 1, as compared to those with metabolic syndrome or metabolic syndrome plus type 2 diabetes, the risk is 3 times. And the problem amongst the Indian population is that they have this collection of risk factors at a very young age. These risk factors are not diagnosed, not identified, not treated until they have an event. And all we try to keep saying, or maybe keep telling us or justify that, oh, Indian people are genetically prone to get heart disease. Well, they're not. All they have is risk factors at an early age which is not treated. And what we need to do is to treat their risk factors. So the cardiometabolic risk factors tend to cluster in individuals. And that's why I've kept abdominal obesity in the center of it. Because with abdominal obesity comes at least pre-diabetes or diabetes, hypertension, abnormal lipids in terms of low HDL, high triglycerides, abnormal ApoA1 to ApoB ratio. There's inflammation markers of high sensitive CRP, and they are prone for high ischemic event rates. That is shown from this slide, that bigger is your abdominal girth, bigger is your risk of dying from ischemic heart disease, stroke, or renal failure. This slide may not show tell the whole story, but the problem amongst Indian population is that we have a relatively higher fat in the body as compared to the muscle mass. Even if the individuals from India are slim, they still have abdominal obesity. And with abdominal obesity, there is a fat which goes into the liver. And as the liver fat is more than 10%, it spills over as free fatty acids in the blood, which is a chemical toxin to the beta cells of pancreas, causing type 2 diabetes. So what do we do? Well, if we try to do secondary prevention in patients who have had mitral infarction, we have to put them in a cocktail of medication. A cocktail of aspirin plus minus Plavix or ticagrelor, lipid-lowering drugs, ACE inhibitors or ARBs, beta blockers, and increasingly aldosterone receptor antagonist eplerenone for those patients who have shown signs or symptoms of heart failure. We know that those people who are on more than 2 drugs for any disease, they have very low compliance. So we have problems of polypharmacy in patients with previous myocardial infarction or people with multiple risk factors. They are on polypharmacy. They have a problem with compliance. They have a problem with adverse effects. And it's a problem with affordability in India. So then what do we do? I'm not going to encroach onto the presentation of my next colleague about risk factor modification by using a poly pill, but it's a great idea which has been brought to reality by Catalan Pharmaceuticals with hard work. It is not very easy to combine all these 4 or 5 medications together. It's a very, very big challenge to make a formulation which is stable. So, if a compliance is a problem in individuals, if they can take 1 pill, the main problem amongst Indians is that even if you tell them that you have risk factors which need 2, 3, 4 medication, they tell you, but I'm all right, doctor, why should I take some medication? But if you can tell them that you have to take only 1 tablet or 1 capsule, they will like the idea. As the theme today is innovation, I would like to share some knowledge with you today, what we are doing in London at the moment. As I said, that 50% of deaths after myocardial infarction in the first year are sudden deaths. So what we do is identify these individuals who are at risk of dying suddenly, and we put implantable cardiac defibrillator in them to shock them out of VT or VF. What I have to do is, I have to puncture their subclavian vein to get 2 big leads into them, which goes into the heart. So there are risks associated with that. Risk with lead, risk with pacemaker, infection, pneumothorax, hemothorax, cardiac perforation. To overcome that, I'm now just putting a subcutaneous ICD, where the lead is purely subcutaneously put in. So we avoid the venous system puncture and avoid the risk of hemothorax, pneumothorax, and cardiac perforation. This has just come in the last 3 or 4 months. It has not been done as such at the moment in India, but I'm sure it will be coming. Briefly touching on to hypertension, in about 15 to 20% of the hypertensive population is resistant. Resistant means despite being on 3 medication, the blood pressure is not controlled. Or, despite being on 3 medication, their blood pressure although is controlled, but they have evidence of end organ damage, left ventricular hypertrophy, eye disease, kidney disease, and stroke. So if you look at the blood pressure, the mortality risk doubles with each 20/10 millimeters of Hg increase in blood pressure. You have seen that 50% of all heart attack patients in India have hypertension. So one risk factor which is absolutely necessary to be controlled is hypertension. We also know that 70% of these people in India have hypertension and diabetes together. And you clearly see from this, there's a double jeopardy, that your risk of dying is actually much more in individuals who have diabetes and hypertension together. What do we do for these people? There are 15 to 20% of these patients who do not have blood pressure control despite being on 3 or more drug treatment. In these individuals, they have high sympathetic tone. Sympathetic nerves are around the renal artery, mostly in the adventitia. And what we do is, we try to destroy them, what we call ablation. Now there is a 3rd and 4th generation ablation techniques available now. One of them is ultrasound balloon-based treatment, which you can see in the angiogram, where we go into the renal artery, we inflate the balloon and push a button, which actually causes ultrasound going through that balloon, creating heat energy and destroying the sympathetic nerves around the renal artery. This is a hardly 20-minute procedure, which I take 20 minutes for this procedure. And the results are stunning. I would say, if I'm being modest, that about 20 systolic over 12 diastolic is achieved by doing that. So either you can reduce the number of tablets these individuals are taking and address the risk as well. So therefore, friends, please think about cluster of risk factors, think about difficulty even diagnosing or treating them, and maybe a concept that if we can start them on a poly cap early in life, we will save millions of lives, which Mr. Indravadan Modi did save over the years by that patent law. If we don't do that, we are going to shift the focus from young adults to children in this way. They are going to become obese, which are already becoming like this, with fast food being very popular in India. And we might see on the roads obese children crossing. Beware, childhood obesity. The shape of things to come. This is how man is evolving. So if I might summarize, Indian population with risk is younger, prone to myocardial infarction at earlier age. 25% MI before the age of 40, 33% before the age of 45, and 50% before the age of 55. The population is sicker. 4-fold higher risk of MI as compared to Europeans. 2-fold higher mortality after an MI compared to Europeans, although the treatment is the same. 2-fold higher incidence of coronary artery disease. In South Asians, 10.7%. In Europeans, 5.4% of the community. 60% of world disease burden borne by Indians is 70% of the population. Excess burden of conventional or metabolic risk factors, shortage of protective behavioral factors, emerging genetic glucose insulin inflammatory markers. So immediate priority is to achieve highest long-term impact and early risk factor modification. Thank you.